The dim glow of a bedside lamp flickers across the room, casting long shadows that dance like forbidden secrets on the walls. A man in his 70s stares at the ceiling, his heart pounding not from passion, but from frustration, the kind that gnaws at the soul after years of chasing what once came so effortlessly. He's tried the pills that promise miracles, the devices that hum with mechanical hope, the waves that shock the body into submission, yet nothing stirs. What if the answer isn't in a bottle or a machine, but in a needle's prick, a toxin's whisper, or a surgeon's blade? Tonight, we unravel the hidden paths to reclaiming desire, pulling back the curtain on treatments that Big Pharma whispers about in hushed tones, therapies that could rewrite your story or leave you forever changed. Hold your breath, because what you're about to discover might just save your intimacy or shatter illusions you never knew you held. And it all starts with one man's desperate question that echoes in clinics worldwide. Welcome back to the Reena Malik MD podcast, your ultimate source for evidence-based information about sexual health and beyond. I'm your host, a urologist and pelvic surgeon dedicated to breaking down the barriers of embarrassment and misinformation. Today, we're diving deep into our Ask Me Anything segment, where real questions from real people like you get raw, unfiltered answers. This is the space where members submit their most pressing concerns, and we tackle them head-on once a month. The first half of this episode is shared freely on the platform, but if you're craving the full unedited journey, the juicy details, the extended explanations, and the bonus insights, head over to ReenaMalikSupcast.com and sign up for membership. There, you'll unlock the opportunity to submit your own questions, gain early access to every podcast episode, and even download transcripts to revisit the wisdom at your leisure. No more waiting, no more wondering, just pure, actionable knowledge delivered straight to you. With that, let's plunge right into the heart of today's inquiries, starting with a query that's as poignant as it is pervasive. Our first submission comes from a 70-year-old gentleman battling what he describes as intermediate to high ED. Let's clarify that right away as moderate to severe erectile dysfunction. This isn't a casual hiccup. It's a relentless barrier that's persisted despite an arsenal of attempts. He's sampled Viagra, experimented with vacuum pumps, endured shockwave therapy sessions, and even strapped on constriction rings. In short, he's exhausted the usual suspects, the go-to remedies that fill pharmacy shelves and late-night infomercials. At his age, with severity ramping up, he's left wondering, what's next? Is there a lifeline, or is this the end of the road for intimacy? Buckle up, because we're about to map out a comprehensive roadmap, layer by layer, peeling back the complexities of ED to reveal options that could reignite the spark. To truly grasp the solutions, we must first circle back to the root of erectile dysfunction itself. ED isn't a singular villain. It's a symphony of potential culprits, often harmonizing in older men like our questioner. The most common conductor, blood flow issues. As we age, arteries harden, plaques build, and circulation falters. Think of it as traffic jams in the highways leading to your most vital destination. When I evaluate a patient in my clinic presenting with ED, the investigation begins holistically. We draw blood to check cholesterol levels, those sneaky lipids that clog vessels everywhere, including the delicate ones in the penis. Diabetes, a frequent accomplice, with erratic blood sugars damaging nerves and endothelium alike. Blood pressure. Readings come under scrutiny too, because hypertension is like a constant squeeze on those pipes. Optimizing these isn't optional, it's foundational. I always emphasize, what's good for your heart is gold for your erections. Adopt a Mediterranean-style diet rich in leafy greens, nuts, olive oil, and fatty fish. These aren't just trendy. They combat inflammation and enhance endothelial function. Exercise? Aim for at least 150 minutes of moderate aerobic activity weekly. Brisk walks, cycling, swimming that pumps blood efficiently. Training your vascular system like an athlete preps for a marathon. Now, let's dissect what he's already tried, because understanding failures paves the way for successes. Medications like Viagra, sildenafil, Cialis, tadalafil. These PDE5 inhibitors are frontline warriors. They've been dissected ad nauseum on this podcast and my YouTube channel, but here's a refresher. They amplify nitric oxide's effects, relaxing smooth muscles to flood the penis with blood. For many, they're game changers, kicking in within 30-60 minutes and lasting hours. But in moderate to severe cases, especially with underlying vascular damage, efficacy wanes, side effects, headaches, flushing, nasal congestion, tolerable for most, but not universal panaceas. Vacuum erection devices or penis pumps enter the scene next. He's given them a shot, and rightly so. They're non-invasive mechanical aids. The principle is straightforward. A cylinder creates negative pressure, drawing blood into the corpora cavernosa, engorging the tissue. Then, a constriction ring slips to the base, trapping the blood for up to 30 minutes of rigidity. Sounds simple, yet pitfalls abound. The ring must fit precisely. Too loose, and blood escapes. Too tight, and discomfort ensues. Sometimes bruising or numbness. Patience is key. There's a learning curve. Start with lower suction. Cycle gradually. Many abandon them prematurely, frustrated by the ritual. But mastered, they deliver reliable erections without drugs. Ideal for those with medication contraindications, like nitrates. Shockwave therapy. He's endured the sessions where low-intensity sound waves pummel the penile tissue. Marketed as regenerative, it induces microtrauma, summoning growth factors to sprout new vessels via angiogenesis. Promising for mild to moderate ED, where blood flow is impaired but not obliterated. Studies show improvements in IRIF scores, with some men ditching pills altogether. However, for moderate to severe cases in septuagenarians, results dim. Why? Advanced atherosclerosis means vessels are too scarred, too calcified for meaningful neovascularization. Plus, if ED stems from non-vascular causes, low testosterone, neurological deficits from prostate surgery, or medication side effects, shockwave falls flat. It's not a cure-all. Efficacy hovers around 50-70% in optimal candidates, per meta-analyses. Constriction rings, often paired with pumps, deserve a nod. Standalone, they're basic rubber bands essentially, but medical-grade versions vary in tension. The goal: maintain tumescence post-stimulation. yet prolonged use risks ischemia if over-tightened. With these exhausted, hormones demand attention. Testosterone isn't just for libido. It primes penile tissue responsiveness. In older men, levels naturally decline. Hypergonadism exacerbates ED. A morning serum total testosterone below 300 NHDL warrants scrutiny, alongside free testosterone and SHBG. Replacement via gels, injections, or pellets can restore vigor, but cautiously. Monitor PSA, hematocrit to sidestep prostate risks or erythrocytosis. Medications review is crucial. Beta blockers, SSRIs, diuretics often sabotage erections. Swaps might suffice. If pillars crumble, escalation beckons. Enter intracavernosal injections, ICI, the game changer for refractory ED. Picture this: a tiny insulin-like needle, 30 gauge, delivering alprostadil, papaverine, or combinations, bimix, trimix, quadmix, directly into the corpora. Fear factor: high initially, but patients in office trials gasp. That's it. Pain minimal, akin to a pinprick. Mechanism: direct vasodilation, bypassing systemic hurdles. Onset: 5 to 15 minutes. Duration: 30-60 minutes. Reliability: 80-90% even in severe cases. Dosing titration is art. Start low, e.g. 5 tas 10 Hastav Viagra alprostadil. Increment if needed next session, not same day, to avert priapism, that dreaded prolonged erection. For 4 hours demands ER intervention, aspiration, phenylephrine injections to detumescence. Scarce but serious. It underscores respect for protocol. Formulations abound, compounding pharmacies' customized strengths, making personalization profound. Beyond injections, regenerative frontiers tease. Platelet-rich plasma, PRP, the so-called P-shot. Centrifuges your blood, injects growth factors. Anecdotes abound, but RCTs, sparse, equivocal. Improvements in mild ED, perhaps placebo-driven. Stem cells, hype outpaces evidence. Adipose-derived or bone marrow injections, experimental, costly, unregulated in many locales. FDA cautions apply. Proceed skeptically. Then, an intriguing outlier. Botox penile injections. Yes, botulinum toxin, famed for wrinkles, repurposed for flaccidity. Injected into smooth muscle, it paralyzes constrictors, facilitating relaxation for inflow. Rationale: ED often initiates with failed smooth muscle unwind. Pilot studies on severe cases, implant candidates, yielded 30% spontaneous erections post-single dose, lasting months. Mild ED, up to 90% response. Moderate, 50%. Safety profile stellar. Minimal diffusion risk. No systemic botulism. I offer it selectively. Patients report enhanced medication response. Natural feel. Duration, 3 times 6 months. Repeatable. Not mainstream yet, but data accrues. Should all falter, penile prosthesis looms. The gold standard for end-stage ED. Inflatable devices, 3-piece, pump, cylinders, reservoir, mimic physiology, squeeze scrotal pump, inflate for rigidity, deflate for flaccidity, semi-rigid, malleable rods alternative, always firm but bendable. Satisfaction rates soar, 85 to 95% for patients and partners. Surgery outpatient, risks infection, 1 to 3% with antibiotic coatings. Mechanical failure, 5 to 10% over decade. But for our 70-year-old post-exhaustive trials, it restores spontaneity, confidence. We've covered implants extensively elsewhere. Videos, detail animations, testimonials, shifting gears. Our next query probes. Menopause diagnostics. Is there a blood test? Menopause, retrospectively defined as 12 consecutive months amenorrhea, hinges on clinical history, not labs. Post-cessation. Estradiol plummets, 30 post-PG ml. FSH surges, 30 IUL. Confirming ovarian failure. But testing. Unnecessary for diagnosis. Perimenopause. The turbulent prelude defies snapshots. Hormones fluctuate wildly. Estrogen peaks one day, crashes next. Progesterone erratic. Day 3, cycle FSH might hint ovarian reserve, but symptoms reign. Hot flashes, night sweats, vaginal dryness, mood swings, irregular bleeds. Diagnosis? Conversational, symptom-based, hormone replacement therapy, HRT, viable in peri or menopause if symptoms debilitate. Estrogen, patches, gels, pills, alleviates vasomotor woes, genitourinary syndrome, progesterone counters, endometrial hyperplasia, if uterus intact, roots, transdermal preferred, bypassing liver, minimizing clot risk, benefits, bone protection, cardiovascular in early menopause, 60 years or 10 years post, symptom relief, risks, breast cancer nuance, estrogen only safer than combined, strokes, clot, individualized via history, no prior DVT, smoking, migraines with aura, alternatives, SSRIs for flashes, uspemiphene for dyspareunia, lasers for atrophy, post-HRT initiation, levels occasionally check absorption, gels vary by skin. Membership beckons for the untruncated voyage. Early episodes, transcripts, question submission, community camaraderie, and Reena Malik. .supicast.com. Invest in your health. Remember, self-care isn't luxury. It's necessity. You're worth it. But wait, the journey doesn't end here. Let's expand on ED's nuances, because our gentleman's story resonates with millions. Vascular health optimization merits deeper dive. Beyond diet and exercise, consider sleep. Apnea fragments nocturnal erections, testosterone, weight loss. Each 10 kilon shed boosts IEF by points. Smoking cessation, nicotine constricts, quitting reverses in months. Alcohol moderation, excess depresses, CNS set PDE5 caveats. Tadalafil daily, 2.5 semi-5 ngin, for spontaneity versus on-demand. Food delays sildenafil, empty stomach optimal. Interactions. Alpha blockers demand spacing. Pumps mastery. Lubrication eases seal. Multiple sizes trial. Combine with PDE5 for synergy. Shockwave protocols. 16 hour 12 sessions. Energy levels tailored. Gains plateau. Maintenance debatable. ICI mastery. Teach self-injection sideways. Ice pre-numb. Storage refrigerated. Super trimix potency for tough cases. Botox mechanics. 100 units distributed. Ultrasound guided optional. Synergistic with PDE5 on implants evolution. AMS 700 with inhibizone. Coloplast Titan touch pump. Refinements reduce revisions. Menopause spectrum. Surgical. Oophorectomy. abrupt, POI premature. HRT timing window, critical. Initiate early maximizes cardio benefits per WHI reanalysis. Symptoms management, moisturizers, lubricants for intimacy, pelvic floor therapy for incontinence. The suspense builds. What if lifestyle alone sufficed? Kegels strengthen, but for ED, aerobic trumps. Supplements, L-arginine, citrulline boost, no. Modest evidence. Ginseng, yohimbine anecdotal, psychogenic ED layer, even organic, anxiety amplifies. Therapy, mindfulness, future horizons, gene therapy, tissue engineering, penile regeneration sci-fi, becoming reality. Our questioner at 70 embodies resilience. With injections or beyond, hope persists. Intimacy evolves. Focus connection, not perfection. Perimenopause roller coaster. Track cycles. Apps aid pattern recognition. Non-hormonal. Fezolinetant for flashes. Novel NK3 antagonist. CHAR-T formulations. Compounded bioidentical trendy, but FDA-approved standardized, safer bone density. Scans post-menopause guide, bisphosphonates if needed. The hook lingers. In shadows of doubt, light pierces. One prick, one relaxation, one implant. Transformation awaits.